we have options of cemented, non-cemented, and now recently we have a dual mobility options is also available. So I'm just going briefly about tell the cemented first. The cemented is we can use and it is little cheaper and not supporting patients. We can use it, and severely osteoporotic bone. If you are not able to get a good fit with uncemented cup, we can use it. Problem with this cemented stems, cemented cup is the 28 head. The dislocation is risky, and it is a lot of learning curve. Unless you have been trained in that, if you try to use the cemented cup, the bottoming out, excessive cement, all the issues. So every time the reproducibility with the cemented cup is a little concerned. So unlike the uncemented cup and stems, where it is easily be done. So there is another cup in cemented. Recently, it has come with I think Rim Fit Cum, which has made up of an highly cross-linked poly, unlike the other cups which has been earlier was a conventional poly, where you can use a 32 millimeter head. In that, what is the principle is where we can rim cut the edges, where the cup will sit very well, and bottoming out the cup will not be there. Exact size will be you can get, and now all these cemented earlier cups was 4-5 millimeter difference was there. This is has an advantage of a 2 millimeter difference, so that the fit will be far better and the cementation will be far better. So to get the proper cement mat quality with this rim fit technique, we've been using it, and one of the best technique, and we can use it some of the patients where you can't think of uncemented. So this is a rim fit cup where exactly you can sit, the edges are rimmed and the cup will sit exactly in the center. There won't be any bottoming out of, there won't be anything. So this is an example where you can see the patient was not affording, where it could have been used uncemented cup. But this is our reaming, and this is how with the post-op X-ray, where you can see the good cementation all around. So the uncemented, I think everyone knows about it. I think it is routinely used. Mainly all these cups are made up of titanium, porous coated, and some of them are HA coated. And Pinnacle system is HA coated. All these companies have HA coated also available. HA plasma spray also is available. There's another cup which is called tantalum, which is made up of highly porous, which is being used in revision scenarios or primary complex scenarios. We can use it. So the tantalum and the Gription cups are all useful if there is the high porosity, high coefficient of friction, which has been used in revision scenarios. So all these uncemented cups design is very important. We should know before using it. The hemispherical is very commonly used, and this is easy to use, and line-to-line reamer or 1 millimeter, 2 millimeter under ream. If there's suppose we use a Pinnacle type of system. See, some of the companies have elliptical system. You should understand it before using it. The elliptical system is that if you can see that unlike the peripheral is enlarged here. So the peripheral fit is more than the bottoming out fit. So in these cases, we need to do a line-to-line reamer rather than like under 2 millimeter ream will not work. So otherwise we'll have fractures. So the surface coating is different companies have this sintered titanium, cobalt chromium beads, and titanium fiber metal mesh with the Zimmers. So all these have a long-term track record, and different coatings only available. On basically even this HA coating also with the Striker which has it, but again in this case we need to make sure that the fit of the cup is very important. These are the elliptical cups. Line to line is very important. And if you do undersize it, maybe difficult to get the the HA coating. Suppose if the HA coating is not fit very well, like a titanium one with Striker ones, where you need to fix with the additional screws. Otherwise, the HA will absorb and the patient get have a loosening. And that small uncemmented cups is called Bantalum cups, where you can use it in dysplastic hips, and very useful for the thing, but we should know pre-operative templating or pre-op x-rays where the dysplasia, you can use it. And dual mobility has been using very useful in case of you want to do a total hip in a flexion neck femur, unlike bipolars in engaged patients, we can use it. And trochanteric fractures and a fused spine where you can keep this dual mobility. There is two types of dual mobility is available. One is a modular one and a non-modular. The modular one is the advantage is a single piece design, is a monoblock. So there is no additional metal liner will not be there, and there is no additional, the only problem is that there is no screw fixation is available. It is a press fit like a metal on metal earlier. So we need to be very sure about the fixation. And this advantage is that there is no additional metal liner, and very good fixation if you get. This is a wonderful implant. So the dual mobility works on, like unlike the normal THR, where this cup stem will edges on this and impinges and it dislocates. In case of here, in dual mobility, the principle is this is the cup and this is the unconstrained liner. And moment the neck will impinges, this cup, the liner will try to prevent the dislocation. This is the advantage of the dual mobility. So the France company has the ability to have a dual mobility. It is a wonderful implant. And the other companies have this modular one dual mobility where the additional metal liner comes. Wherever you feel the primary is little tricky and the instability is risky, you can keep this option. But you always be concerned about additional metal liner can cause a metal ion issue and can cause loosening. There's papers are present, publications are there. So these are example like fraction neck femur. We used dual mobility, one of the best implant where you can, without any patient, if you use a bipolar, the groin pain is an issue, where you can use this and you don't have any pain or issue that the patient mobility is very good. And there's another case where IT fractures were completely proximally, very much malunited and very grossly fixed deformities, where dislocation is always risky. So I used the dual mobility and uncemented step. The patient is mobilized with a knee problem. Like a PFN failures, where dual mobility and totally, it really gives a good relaxation. And severely bad IT fractures, where again dislocation is risky. So I use this. So these are both the dual mobility uncemented and cemented cups.